Hello, everyone. Welcome to another Friday session. I'm really excited to have a guest with me today. His name is Dr. Thomas Weimbs. He's a PhD researcher and professor at University of California, Santa Barbara, and he's also the president and founder of Santa Barbara Nutrients. And what we are going to explore today together is polycystic kidney disease, chronic kidney disease, and gout. Thomas is an expert in the area of polycystic kidney disease. He's going to talk to us about the connections between PKD and chronic kidney disease and gout.
Yeah, thank you, Pete. Thanks for having me. Looking forward to our discussion. As you know, I'm a professor at the University of California at Santa Barbara in the Department of Molecular, Cellular, and Developmental Biology. That's sort of my day job, if you will. And, the rest of my time I spent as the president of a company that we have founded recently called Santa Barbara Nutrients. That's based off of research from my lab at UCSB and many other people's research as well. So I have kind of two hats that I'm wearing and happy to answer with both things in mind. Any questions you might have?
Cool. Very, very cool. So what I want to ask you first about is the molecular basis of polycystic kidney disease. And what I'm interested in, and so that the listeners also understand where I'm coming from, I see a connection so far between the research that I've read that you've published, chronic kidney disease and gout. And where I see this connection is the fact that about 71% of gout sufferers also suffer from chronic kidney disease. And in some past interviews I've heard with you, you've talked about the connection between polycystic kidney disease biochemically, and I think that's correct, but you're going to correct me coming up, and chronic kidney disease. And the reason this is important to gout sufferers is because I think there's probably a common mechanism that's going on here. So maybe you could first describe for the listeners what exactly polycystic kidney disease is and how it's connected to chronic kidney disease.
All right, good question. Yeah, so in my research lab at UC Santa Barbara, we have focused on researching polycystic kidney disease, or PKD for short, for 20 plus years. And we've studied molecular pathways and to try to understand what is the underlying what are the underlying signaling pathways that go wrong and so on. What is PKD? It's a genetic disease. So patients that are affected have a typically a gene mutation in one of two genes, either PKD1 or PKD2. PKD1 is a more common version. Typically patients would have inherited a defective gene from one of their parents. So about 85% of the cases, there is, it's an inherited form. The disease leads to sort of like a slowly progressive chronic kidney disease phenotype, and it's almost pre-programmed. So patients typically will get chronic kidney disease. However, the rate of progression can be highly variable. So some people are affected very early on and they progress very rapidly to renal failure. Other people, are very, very slowly progressing. They may never develop renal failure in their lifetimes. And this can all be classified, for example, by taking a snapshot of the patient, by measuring their total kidney volume, it's called, and it's usually done by MRI scanning. And it takes advantage of the fact that in PKD, the kidneys grow, and they can grow really enormously to enormous sizes. So normal kidneys, are the sizes of, of your fists roughly. In polycystic kidney disease, they can get many times that size, football size and even more. This kind of slow progressing growth of the kidneys, you can measure this in MRI scans. You can calculate what is the total kidney volume of those kidneys. And if you look at a certain patient at a certain age, you measure their total kidney volume, you can predict whether they are fast progressing, a patient slowly progressing, and you can sort of estimate what the time will be until they reach kidney failure. And about, at least half of the patients will progress to kidney failure at some point. And then, of course, as you know, the options out there are, going on dialysis, hoping for a kidney transplant. So that's in a nutshell what PKD is. And actually, maybe I should add to this. So in contrast to the typical chronic kidney disease, where the kidneys don't really grow in size, so in PKD they do grow, and the growth is due to the formation and growth of thousands of cysts, and these are, just like ball-shaped structures, if you will. They're fluid-filled. They're lined by a layer of epithelium, and they just relentlessly grow over time. So they form and they grow, and they form and they grow. And in the process of growing, they're thought to kind of destroy the normal renal tissue and eventually cause the functional loss in the kidneys.
So just listening to you, I have the first burning question I have is that, so we have this genetic disposition to this disease. The question is it a foregone conclusion, or is this something that if an individual early on in life eliminates sugar, basically, where I'm going with this, eliminates the fructose load and perhaps hyperglycemia from their daily meals, is it a foregone conclusion with the genes that they're going to end up with polycystic kidney disease?
Well, great question, Pete. So until recently, I think everybody has said, okay, you have the defective gene, you get the disease, there's nothing you can do. And that literally every single patient has probably heard this, and at some point, from their doctor, from other patients. You go on social media, all these, Facebook groups, self-help groups, they keep hammering this into people, saying, hey, it's a genetic disease, you can't do anything about your genes, you might as well give up and die. So I don't think that's true at all. What is true, of course, is, if somebody has the gene mutation, they do have polycystic kidney disease, so there's no way around it. However, the severity of the disease can be highly variable. And I think there's a good case to be made that patients can affect how severe the disease will be, how fast it will progress. And so I don't think it's hopeless for patients to just say, hey, I got a defective gene, nothing you can do. I might as well eat whatever I want, enjoy my time and, eat at McDonald's all day long, for example, right? So I don't think that's that's the solution. But unfortunately, until, very recently, that's pretty much what every patient has been told. And, we have been maybe on a mission a little bit to change that mindset and to say, hey, we think there is something you can do about it. There are certain things you can avoid to avoid having a worse progression. And, here's what they are.
Yeah. Well, you guys, I think our listeners need to hear this. You guys are actively doing that. Your research group in combination with your company, right? You guys are reversing. Is reversal too strong a word, or can I say that you guys are reversing this, right? It's a plant-based, you're using plant-based ketogenic diet, medical food to actually reverse this, right? Is that an overstatement?
Well, right now, so, I wouldn't say that way yet, because
Okay.
this really needs to be shown and documented in clinical studies before anyone believes it. And in fact, the reversal word, the R word, if you will,
Yeah.
has been like a bad thing in polycystic kidney disease research. If anyone ever brought up, oh, maybe PKD can be reversed, they got laughed out of a room full of scientists. And it has just been thought of as an irreversible disease, relentlessly progressing, getting worse and worse and worse over time, never gets better. However, in my research lab at UCSB, we've already published, more than 10 years ago, that we can reverse the disease in mice with PKD.
Right.
And that was done with a terrible drug, if you will, called rapamycin. It's an mTOR inhibitor. It's used as an immunosuppressive drug. And if we treat these mice with sort of industrial amounts of rapamycin, we could show we can reverse the disease. And when we published those results, we almost made it a footnote because, the people would just not accept that. So it's out there almost, like in one panel, in one figure, and mentioned in half a sentence that high dose rapamycin can actually reverse existing cystic disease. And then more recently, excuse me, more recently, about 3 years ago, we showed that ketogenic diets can also reverse the existing disease, again in animals, in rats with polycystic kidney disease. So we were a little bit more bold and put it, had maybe 2 sentences about it in the paper. And I think nobody still noticed that. But, very clearly we can see that existing renal cystic burden gets better after after a ketogenic diet. So we published this about 3 years ago. And only this year, another study came out from Steve Sumlow at Yale University, where they did, very nice, fantastic study with sort of genetic trickery in mice, where they could first knock out the PKD1 gene, and then later, after the mice have developed PKD, they can re-express it again, and they found, ta-da, they could reverse the disease. Now at least 2 groups have shown that you can, at least experimentally in animals, you can reverse the disease. The idea of Somlow's paper was that this was done by essentially genetic rescue, which is not something you can ever really do in patients. But so patients still think, great, this works in mice, but it's hopeless for us. However, we have already shown you can do it by pharmacological intervention, by dietary intervention. So same results. You can actually reverse the disease to a certain degree. I wouldn't go as far as saying that therefore the same interventions will be able to reverse anything in patients. Patients are complicated. They're not mice in a cage. They're not all genetically the same. They live in the wild. Excuse me. They don't live in a clean cage. And they're, have all kinds of additional challenges being thrown their way. So to overcome all these, I think it's a taller order than just to change the food of a mouse in a cage, that has no other choice but to eat that food.
Right. It's a lifestyle. No, I get that, because the other half of me does coaching, and to try and help people put gout in remission, and then also I have clients in the diabetes area and cardiovascular disease. And, yes, it's a lifestyle issue. And so it's super complex, and there's a lot of compartments to it. And, I think one of the biggest challenges for people out there are the willingness to really look at their whole lifestyle, everything from obviously what they're eating down to, the level of sleep that they're getting. And that makes, yes, I think that's the biggest challenge from my point of view of what we do out here. But would you think it's fair to say that you are improving the condition of people with polycystic that are willing to make the commitment to your program? And
I would definitely say yes to that. And it's probably in the realm of anecdotal data, because we haven't done a rigorous clinical study, with controls and all. However, we have set up a dietary intervention program called the Renew program. So it's REN.NU, so for renal nutrition, but it rhymes with renew, renew your kidneys, if you will. So this program is really a fantastic collaboration with a terrific group of renal dietitians led by Jessiana Saville and Diana Brun. We got together 2 or 3 years ago when our studies first came out. Jess heard about them. We met, and they're private practice dietitians, so they have been treating patients with chronic kidney disease, for all their career, and treating them with, I think, very, very sensible dietary changes and having really good success with that. So we got together and said, hey, we have all this research in animals that suggests that dietary changes would be beneficial in PKD, in patients with PKD. You guys have all the clinical experience treating patients with chronic kidney disease. Let's stick our heads together, see what we can do to actually come up with something practical. And that's exactly what we did. So that's, they created this Renew program that is run by a nonprofit company and started officially in January this year. Prior to that, it was tested in a beta test in the summer before that. And the beta test was on about 24 patients with PKD. I would say with phenomenal results. A lot of the patients reported improvements in pain levels, for example. A lot of them lost weight, obese and overweight patients. A lot of folks, reported many other sort of improvements in PKD, typical symptoms, including improvement in hypertension, as well as in eGFR, this magic number, the glomerular filtration rate that patients tend to monitor very closely to see how far along they are on the progression of the disease. So all this, so this was not a clinical trial yet. There was no control group, it wasn't rigorously done like it would be for a clinical trial, but so I would still call it a collection of anecdotal data. But, if so many people say the same thing and they swear by it afterwards and actually stick with it, I think that tells me something. Plus, by now, over 100 patients have gone through the Renew program already. And it's been just consistent that patients seem to get a lot of benefit from it. And this program is essentially a plant-focused ketogenic diet that avoids renal stressors, including uric acid precursors, but also oxalate and phosphate and so on.
So I looking at the Cell paper, you mentioned the Warburg effect. I want to try and get into the complexities a little bit, because from my point of view, when I look at your work, and I look at the work of Johnson, and I also looking at the body of osteoarthritic data that's out there, because I'm interested in the what's going on in the joints with gout. Basically the uric acid. Johnson's described a Warburg effect too at the level of the proximal tubules, right? And one of the things that I found, this was a 2021 paper, and I think they have data that showed that the uric acid, which was added exogenously, right? And this is the thing that I found was really profound with his paper, because I'm trying to understand the difference between intracellular uric acid that gets produced when you have what I call the deadly triad. So the arrival of alcohol, hyperglycemia, and fructose all arriving in the circulatory system at the same time. That they had data that showed that under hyperuricemic conditions, the uric acid could enter the proximal tubule cells via its receptor, right? And then elicit the same effects on the inflammational cascade, the disruption of nitric oxide pathway, downregulation of the mitochondria. So when I'm looking at your work and I'm looking at his work, I'm thinking, all right, fructose metabolism looks like it has something to do with that. And there's a commonality. I don't know. I want to hear your opinion about that, literally. But also, you talk about the Warburg effect, and so does Johnson. And the reason why this matters to me is because the chondrocyte, which is in the joint, which seems to be at the business end of osteoarthritis, and I also think at the business end of gout, most likely, the chondrocyte is a specialized glycolytic cell. And in your system and in Johnson's system, there seems to be this effect when we get the fructose metabolism activated, or the effect of uric acid, that this may be driving this glycolytic state, right? And I don't know. What do you think about this? Have you guys looked for fructose metabolism in the polycystic kidney disease pathway?
We have not looked at fructose metabolism, and I don't think anyone else has, to my knowledge. However, I should maybe elaborate a little bit on the Warburg effect in PKD. Yeah. So that's something that has come out, over the last few years by a number of labs where they found, coming from kind of different angles, found metabolic abnormalities in these cyst lining cells in polycystic kidney disease, as well as mitochondrial structural and functional defects. So it appears that these cells kind of ditch their mitochondria, and actually maybe I should first back up what is the Warburg effect. So that's something, that was discovered by, Dr. Warburg many decades ago, 50 plus years ago, that cancer cells very often have non-functioning or not properly functioning mitochondria, and they essentially turn off the oxidative phosphorylation, which is usually the main way for cells to produce ATP, the energy, but it requires oxygen because mitochondria, they metabolize the oxygen.
Right.
So if you shut off your mitochondria, that seems like a bad idea. However, cancer cells think it's a good idea because it allows them to essentially don't need any oxygen anymore. So they can live in hypoxic environments where there isn't enough oxygen around, and that's often the case in tumors, right? So where they're not very well vascularized and so on. So it gives the cancer cells kind of an edge over everyone else. Plus, there's usually plenty of glucose around, so that the cancer cells can just gobble up all that glucose, the blood sugar, and metabolize it in a sort of inefficient way, using glycolysis and just bypassing the mitochondria, and they still get enough ATP out of it because there's just so much glucose around in a typical person. So it has some other metabolic advantages because if you shut off the mitochondria, your metabolic pathways kind of flow more towards producing fatty acids, for example, which these cells need to support their cell growth and proliferation, right? So they keep building up cell mass so they can proliferate faster. And that's essentially, in a nutshell, the Warburg effect that seems to be kind of turned on by cancer cells, so that they can just grow like crazy. They don't need any oxygen, but they do. That opens up the Achilles heel that they depend on blood glucose, right? So
Right.
cancer cells oftentimes are very dependent on blood glucose, and they're very happy about us Westerners to eat high carbohydrate diets, which supplies them with all the glucose they ever need, right? So if we're eating, all the sugar and all the starches, we are essentially allowing those cancer cells to just do their thing and survive with the Warburg kind of metabolic switch. And the same Warburg switch has been found in polycystic kidney disease as well. These cells that form these cysts, they actually proliferate. They live in a hypoxic environment, and they do the same thing. They shut off their mitochondria. They live off of glucose. And they happily grow and kind of destroy the kidneys in the process, and that's something we have therefore exploited, because the Achilles heel is the glucose. If you just take away the glucose,
Yes.
you're kind of hurting these cells very specifically. All the other cells in the body can usually deal with low glucose levels because they're metabolically flexible. They have nicely functioning mitochondria. They can just switch over to utilizing fatty acids and ketones for energy. But cells that are kind of locked in a Warburg metabolism, they can't. But they cannot switch over to the alternative fuel sources. And that's what we're thinking is actually going on. That's why we think ketogenic diets, or intermittent fasting, time-restricted diet, and so on are beneficial in PKD.
So the cells, just to clarify, the polycystic cells, they actually end up dying because you drop the glucose, provide ketones. By being on a ketogenic diet, there's elevated fat for energy, and the normal cells are functioning, but the cystic cells die. That's the idea here. Is that correct?
Exactly, yeah. So we have seen that in animals. If we're very abruptly turning on ketosis by acute fasting, which is kind of the fastest way to do it. You just don't feed them any food. We actually saw increased cell death in those cyst cells, and it may, we haven't quite clarified all the mechanisms yet, but one of the problems that seems to come up that kills these cells is sort of lipotoxicity, because under fasting conditions, as you know, our bodies mobilize their fat reserve. All the adipose cells, they release fat acids. So fatty acid levels go up. Cells take them up for energy, but these cyst cells cannot metabolize them, right? So they keep taking up all these fatty acids, and they have nothing to do with them because their mitochondria are not functioning. So it seems that they're depositing them in the form of triglyceride lipid droplets, and they get we saw that they get filled up with these lipid droplets and seem to die from that. So, yeah.
So I have my next question goes to uric acid, because I mean, just so the listeners understand, I've been using your product, keto-citra or citra?
Keto-citra, how I call it, yeah.
And now for almost 2 months, and I've seen my urine pH elevated to somewhere between 6 and 6.5. But the thinking behind that, if I understand it, is that if I have crystallized uric acid in my proximal tubes, is this the correct way of thinking? Then with the higher pH, I should be dissolving that, and the uric acid should be effectively excreted into my urine. Is that a correct way of thinking about this?
Yes, exactly. So, as you know, So there are two types of crystals that can come up in people with gout. The one is the one that affects, the joints and so on, and that's monosodium urate crystals. The other is the uric acid crystals that can form in the kidneys. And uric acid is interesting because it is highly insoluble under acidic conditions, right? So if the pH drops to very low values, say 5 or so, uric acid becomes much more insoluble compared to a neutral pH. And that's exactly what happens in the kidney. So in a joint, the pH isn't really that acidic that uric acid would necessarily precipitate, but monosodium urate has kind of the inverse pH relationship, so that actually can precipitate under neutral pH in those joints. And uric acid, requires an acidic pH. And as you know, one of the jobs that the kidney has is to excrete acid. It has a very important role in the acid-base balance in the body. And if our body is a little bit too acidic, the kidney takes care of it by just excreting more acid, and goes out in the urine, which is a good thing normally because your body gets rid of the acid. However, it makes the urine acidic, right? So you might end up with a urine pH of 5, let's say. That seems like a good thing normally, except the one thing that happens is that your uric acid suddenly cannot stay soluble anymore in those kidney tubules. And the kidney has a really hard time to excrete all that uric acid, because if it does try to excrete a lot of it, and the uric acid meets the acidic pH, it will just precipitate and form these microcrystals that get stuck in those kidney tubules that cause all the damage. It can lead to uric acid kidney stones. So I think the kidney is smart enough to know, hey, my pH is too low. I can't pump that much uric acid, out, because otherwise I kill myself, and the kidney doesn't want to kill itself because then the whole body is dead.
Right.
So that's what happens essentially under acidic conditions. The kidney really has this handicap that it can't excrete all the uric acid that it needs to excrete. And then consequently it builds up in the blood and you get all these joint problems. And, of course, you also have the kidney problems, because, there are all these crystals that do precipitate them. Yeah.
Go ahead.
Well, I was going to say, so what keto-citra does, maybe I should explain first for your viewers what that even is. So it's essentially something we have developed based off of our research, and that's it's been developed by the startup company that launched out of the University of California, Santa Barbara, and it's called Santa Barbara Nutrients. We've developed this product called keto-citra, which has a couple of main ingredients, and one of them is citrate, and one of them is a ketone beta-hydroxybutyrate. And this is formulated in a way to also deliver alkaline base. So it's essentially helps with normalizing the urine pH. And it so happens that in patients with polycystic kidney disease, they typically have acidic urine pH, right? So it kind of might be around pH 5 or so, which is not a good thing. And that's something you'd want to adjust a little bit and bring it more back to normal, which is more like, say, pH 6.5 or so, more of a neutral pH. And that's what keto-citra does because of the alkaline load in it. The other component in there is this ketone beta-hydroxybutyrate, which addresses this metabolic change in these cystic cells. And we can probably talk an hour about BHB, but in a nutshell, beta-hydroxybutyrate is this number one is a fuel for cells, but it only works in cells that have functioning mitochondria. And it seems that if cyst cells are exposed to beta-hydroxybutyrate, they don't seem to like that. They're And we were actually trying to work out in the research lab what exactly the mechanisms are. And BHB is a really interesting molecule. It's not only an energy carrier that gets burned for energy, but it's also a signaling molecule. So there's a receptor for it. I call it the BHB receptor, but officially it's called GPR109A. So say that 10 times fast. So it's a G protein coupled receptor, and the endogenous ligand is actually beta hydroxybutyrate. So we're working in the lab on trying to understand whether receptor activation is something that is important in the beneficial effect of beta hydroxybutyrate. But there are actually many other possible signaling effects. So BHB does a lot of things. It's a strong anti-inflammatory compound. So it really tempers down inflammation, which is a big component of progression in polycystic kidney disease as well. So it might be a multifactorial kind of mechanism in how it works. And so BHB is one of the main components. Citrate is the other. And the overall formulation is such that it leads to that it helps to normalize the urine pH. And that's, I think, something you're going for is to kind of help the kidney be able to excrete more uric acid. You really want to make sure that the urine pH is alkaline enough so that the uric acid stays in solution as the kidney is trying to get it out of the system.
So let's see, I think I have three things. Just spare me or give me a second here I don't want to forget, because you said a lot. The first thing is, I'm really intrigued with your work on the role of beta hydroxybutyrate as a signaling molecule. I was just at Low Carb USA, and Stephen Finney talked about his work. I don't know if it's through Verda or with Jeff Volek, but my point is he's actually calling BHB now beta hydroxybutyrate a hormone. So I think the work that you're doing and coupled with this other work, I think is so important, because I think it is pretty clear that beta hydroxybutyrate is a really important molecule for us. And additionally, they also talked about the role or the proportionality between beta hydroxybutyrate and acetoacetate. I'll just throw that out there. I think significantly less is known about acetoacetate, but that there seems to be some sort of a connection between the two of those. Do you think that the keto-citra has effects other than the kidney in terms of helping our system, our bodily system, get rid of uric acid? And the reason I'm bringing this up is because there's a lot of pretty recent data using dual energy computational tomography. That's a mouthful. So using newer imaging techniques, there's a lot of newer data that shows that for people that are hyperuricemic, so not just the gout people, but hyperuricemic people that are asymptomatic for gout, have precipitated monosodium urate all over the body, even including the valves in the heart, ligaments, tendons, the eye. It's actually pretty massive list. And so, and what I'm about to say is completely anecdotal, but on my YouTube channel that deals with gout, I'm starting to get a lot of feedback. And some of these people are super suffering with this uric acid that seems, monosodium urate. Although you raised a point that's interesting, the difference between uric acid precipitation and monosodium urate. And I think I need to look at that closer. But these people have deposition, it looks like, all over their body. I mean, even in the plaques in people that are suffering from cardiovascular disease. So one thing I wanted to ask you about with keto-citra are there effects of this supplement above and beyond what's going on with the kidney, or is that mainly the main effect? And if we are excreting out of the kidney, does that help the equilibrium effect between these other locations? You follow what I'm saying? In other words, if you start excreting more uric acid, which is deposited in the kidney, is that going to help the decrease in these tophi elsewhere, do you think?
I would think absolutely yes. You know, I have to be careful what I say. I mean, I can't make any, you know, like medical claims or anything like this, because, you know, that would have to be studied first. However, I totally agree with you. You know, people that are hyperuricemic, you know, people with gout, you know, they have many problems. And probably we only know, you know, the tip of the iceberg there. Yes. Currently. And, you know, as you just said, because, you know, new techniques are just coming out now, and a lot of the symptoms may be very general sounding, and, you know, you can never really say, oh, that's because of uric acid, or, you know, monosodium urate crystals. So I think that a lot of research needs to be done, but I think it's pretty clear that you would not want persistently high levels of uric acid in your system, because of, you know, all these depositions everywhere. And you know, the typical gout, you know, the joint problems is probably only one sort of very, very obvious and clear and painful symptom, but there are probably many others as well. So I would say anything one can do to help the kidneys get rid of as much uric acid as possible can only be a beneficial thing. And I think that hasn't been very well understood, maybe, that the kidney needs to be able to do its job with sort of a neutral pH, or it can do a much better job with a neutral pH. Strangely, even though you know, if you look in the literature, it seems obvious, and there's a lot of you know, research results over the years and decades that all are saying the same thing. You know, if you alkalinize the urine, or at least make it less acidic, the kidneys can excrete uric acid better. For some reason, beats me why, for some reason that hasn't, to my knowledge, has never been really studied in a clinical study rigorously. It's not clinical practice, to my knowledge. But so people with gout that don't, you know, they get seen usually by rheumatologists. You know, they know all about joints, but they wouldn't maybe necessarily think about, hey, let's help out those kidneys do their job better. So I think there's, you know, maybe if anything, if there's any room for improvement for people with gout problems, I would say look at the kidney as the solution there.
Yeah, I think there's a lot of, I think all this stuff is connected. And when I looked at your work with polycystic, and I look at Johnson's work, and I talked about this a little bit before, and I'm not sure I made the point the way I should have, but we know from his work on the kidney that uric acid can enter from the circulatory system and then elicit these same changes, or the same kinds of pathological inflammation and whatnot that occurs when intracellular uric acid is elevated when you activate the fructose pathway. When I look at the gout story, there's a couple of things there, and this, I made this connection to your work, all right? And that is that you have the chondrocyte in the joint, and that's the primary biological cell there that's responsible for, you know, making the joint work the way it should. And there is data that shows that the polyL pathway is active in chondrocytes. There's not a lot of data on it because, like you pointed out, to me, when I've talked to Johnson about this, when you look at the osteoarthritic data, they've done a ton of research with hyperglycemia, and that is one of the main conditions for activating the fructose pathway through polyol. In addition to hypoxic conditions, which you have with the chondrocyte, right? These two things are very common in somebody who is eating the standard American diet. It's hyperglycemic. And so there is data that shows polyol is active there. And then there's some really recent 2021 that has shown that the key enzymes in the purine pathway, xanthine oxidoreductase and xanthine oxidase, are also activated under these hyperglycemic conditions. And when you, like, this is in vitro, but when you layer on allopurinol, as an example, onto those chondrocyte tissue culture cells, that you inhibit the crystallization, the calcium crystallization of the chondrocyte. This is going back to osteoarthritis. Now, why am I putting all this out there to you? Because I think it's not understood yet what the relationship is between soluble uric acid and the crystalline form of it. When we think about something that could be going on, and I'm not asking you for a medical opinion here, but when we think about, all right, what's going on with uric acid potentially being transported into one of these key cells from the outside, like the situation with a chondrocyte, as that uric acid comes in, it's not a major stretch for me to imagine a situation where the elevation of the uric acid occurs to a point where you get crystallization literally right inside the chondrocyte, like you have in these models that they've published for the crystallization of calcium and whatever conjugate base it's combined with. All right. It doesn't seem that much of a stretch to see this happening in an individual where the uric acid is passing some threshold on an intracellular basis. And how the uric acid gets there, if you have this hyperglycemic event in a hypoxic environment and you have this uric acid spike in the blood because of the way the individual is eating at that moment, and uric acid entering the cell, you have this crystallization event that happens potentially, and then you pull in the innate immune system and whammo, you've got a gout flare. But I think when you look at the data coming out of osteoarthritic, out of their hallway, there could also be a role for uric acid in that. And then when you look at your polycystic stuff, I'm just wondering if there is a role for uric acid in this somewhere, like how the cell is being, how the pathology is progressing with this. To me, it seems like it's an open question. I don't know.
Well, so with regard to PKD, I already know the answer. Okay. Because we have done the work. It's not published yet. So maybe here's a preview of the paper we're putting together. So as you may know, we have previously published that microcrystals that can form in kidneys, that they can accelerate the progression of polycystic kidney disease. And those were, again, animal studies. So basically the idea is, and I don't want to go into too much detail, but the idea had been over quite a good number of years, is that in polycystic kidney disease, besides the gene mutation that everybody carries around with them, you need another thing happening to trigger cysts to form. And that other thing has been shown to be renal injury. And this can be done in mice, for example, with something like ischemia, reperfusion injury, or with nephrotoxins. You feed the mice mercury, and it makes their polycystic kidney disease worse. So if on top of the gene mutation, you also have an injury event, it accelerates the disease, but it causes many more cysts to come up. And what we had published a couple of years ago is we were wondering what is the kind of the relevant type of injury that actually a patient would experience, right? A patient doesn't get mercury poisoning all day long, for example. And we reasoned that a logical form of injury would be microcrystals that actually form in kidneys all day long. We all pee out crystals, by the millions oftentimes. And the most common type of microcrystals that can form in kidneys are calcium oxalate crystals. And it's also the most common type of kidney stone. But, uric acid crystals are not far behind. The uric acid stones are also pretty common. But what we had published in that paper in 2019 was that if you challenge animals that are predisposed to form PKD, you challenge them with oxalate and they form these microcrystals, you can strongly accelerate the disease progression. And we've done the same with calcium phosphate crystals. Same thing, if you increase the phosphate intake in their food, they form calcium phosphate precipitates in their kidneys and have a worse PKD progression. And that was all published, and that's actually one of the reasons why in this dietary program we're avoiding oxalate intake with the diet, and we're avoiding inorganic phosphate intake with the diet, just to kind of reduce these risk factors as a conservative approach, if you will. What we had assumed was that uric acid crystals would do exactly the same thing, as you would think. And we have actually tested this now. The paper is, essentially done. Haven't submitted the manuscript yet. You can challenge again rats with PKD with high uric acid levels, and you have to, it's a little tricky in rats because rats have uricase, so you have to inhibit the uricase to make sure you actually bump up the uric acid levels to sort of like gout style levels. But you can do all this, and if we do this, we see exactly the same thing that we saw with calcium oxalate crystals. So we see uric acid crystals forming in the kidneys that plug up some of the tubules, cause injury. They cause tubule dilation because the tubules are trying to get rid of these crystals by just flushing them out better. And you get accelerated PKD disease progression. So these animals are much worse off. In fact, we found, maybe that leads too much into the weeds, but
No.
I think actually personally that maybe uric acid could be a bigger problem in polycystic kidney disease than oxalate even. And part of that has to do, with how ubiquitous the uric acid problem is, especially in people with PKD. That has already been shown that people in PKD have much higher chance of having high uric acid levels, and that those patients with high uric acid levels have worse progression of the disease. In fact, the incidence of clinical gout is very high in patients with polycystic kidney disease, higher than in the normal population. So there's clearly a strong association there. Also, of course, people with polycystic kidney disease tend to have a certain level of metabolic acidosis, quite a bit actually, that then leads to this acidic urine pH, which then, like we already talked about, makes it harder and harder for the kidneys to actually excrete all that uric acid. So long story short, I think that uric acid is bad for polycystic kidney disease, just as it is bad for chronic kidney disease. And it's probably all the same mechanisms, that it's always these microcrystals that cause injury, microscopic injury. And then all these pathways you were mentioning come into play, the NLRP3 inflammasome activation, for example, which is something we're very interested in. And guess what? A strong inhibitor of the NLRP3 inflammasome happens to be beta-hydroxybutyrate, BHB. which is one of the reasons why we think, this whole combination of compounds that we've formulated into keto-citra actually all kind of works together. Right, so the BHB, for example, would be expected to be anti-inflammatory, and lessen all the subsequent effects of these crystals that come in there. Plus, you address the urine pH, so you actually make the kidneys much more able to excrete and get rid of all the uric acid without harming itself. I think of it in a way of essentially making the kidneys more resilient and more able to deal with all the things that get thrown at it in real life.
I'm really excited for your research. I really look forward to seeing that paper when it's published, for sure. And the more that I'm listening to you here, along with the other interviews that I've seen you in, I'm thinking that your approach to PKD might be something that gout sufferers also should try. Because basically what I tell them right now is I tell them what I did. I don't think I have chronic kidney disease, right? I track my bloods rigorously, but what I advocate for them now is the first thing to do is to stop the alcohol and the sugars. You got to do away with hyperglycemia and the fructose and the alcohol, and then evaluate your system, do the bloods, look at the whole picture, and then if you need to cut into the carbs or make a decision to go that way, that you do that. But as a coach, I've been teaching the meat version of this, but I think that what you're describing is a viable option for these guys, and I hopefully when I post this interview on Friday, people will see this, but I think I need to start talking about this more because people want options, and I don't. And I guess one thing in the back of my mind is I think about the protein, because when we talk about gout, right, when you go out into the conventional wisdom, what everyone talks about is eliminating the high purine meats, but I believe from an evolutionary point of view that having the proper amount of protein in the diet, with variation, not eating one type all the time, is key to this. But I've seen a few interviews from you when your nutritionist is with you talking about this, and it sounds like a viable option. Which amino acids do you guys view as being the ones that are to be avoided?
Yeah, good question. Right. Yeah. So when you mention meat, there's a few things going on with meat. One is that it's higher in purines, so usually than plant-based foods, and of course the purines are the precursors get turned into uric acid. But the other thing in meat is that it's relatively high in the amino acids cysteine and methionine, what's the sulfur-containing amino acids. And they happen to be metabolized in a way that it forms sulfuric acid, so there's actually acid generation. So if somebody eats a lot of meat, the urine pH would go down, right? So you end up with more acidic urine, and that's just a consequence of the kind of the amino acid composition. That could, of course, be maybe almost a bigger problem in gout, maybe than the purines themselves. Maybe it's really both of them together, because I think high uric acid levels is one thing, low urine pH is the other thing, and if you combine them, that's probably what's very detrimental, because the kidney then suddenly can't excrete uric acid anymore.
You're getting the crystallization.
Right. Yeah, you're getting sort of like a bottleneck there, and all of a sudden your uric acid in the circulation just shoots up. So that's the reason why in this dietary program, it's more of a plant-focused program. So it's not vegan or anything like that. So there's still animal foods in there, but we're just trying to make it more plant dominant. This actually greatly helps also to further alkalinize the urine, and that's really well known. A plant-focused diet is much more alkalinizing compared to an animal-focused diet, which we think is very important in chronic kidney disease, polycystic kidney disease. So that's one of the reasons why we tend to not say, okay, be a carnivore necessarily. Being a carnivore is probably totally fine for someone with healthy kidneys, but if someone has compromised kidneys already, then eventually you run into this bottleneck. Yeah.
So we're just bumping up against 1 hour right now, and I want to be respectful of your time for sure. So let me just ask one last question. In our communications between going back and forth about keto-citra, you've talked about tolerance and how one has a certain tolerance to it. Basically, I read your guys' directions, so I was taking it. I eat about 2 meals a day. Depends on how hard I'm working out. Sometimes I'll do 3 meals if I've had a hard workout. But what I was doing was taking it twice a day with my meals, and then, but after talking to you, I've started taking it more liberally. So with my 2 meals, and then sometimes in the middle of the day, if I'm gonna either have a snack or a third meal. What kinds of concerns does one have with that medical food in terms of tolerance? When you talk about tolerance, what exactly do you mean? What should people expect when they take it?
Right. Yeah. I would say it's generally really well tolerated. So most people have no problem with it. There are, and you might know this, citrate, for example, is also used for in kidney stone patients, frequently. And some patients are just more sensitive to the citrate part. So I think there is not really any problem with the BHB part in keto-citra. I haven't never really heard any tolerability issues there. And in fact, BHB, beta-hydroxybutyrate, you seem to be able to eat this by the pound, and there is nothing that happens to you. So it's more about the citrate. That some people are more sensitive to citrate. It might, and I think a lot of it might have to do with the gastrointestinal, the stomach fluid, which has to be very acidic, so that it can digest all the foods as they're coming in. If you drink something like alkaline citrate, which is what is essentially in keto-citra, it kind of neutralizes the stomach acid for some people a little bit. And if somebody already has not enough stomach acid, that can push them over the edge where they get sort of gastrointestinal problems. We've seen this a couple of times, that the patients seem to have GI problems that are already sensitive to that, that don't have enough gastric fluid, or not low enough pH. The remedy for this is actually, and I've actually tried this myself, is to add some apple cider vinegar to the keto-citra, which seems to work quite well. So if that ever happens to anyone that they have GI problems, that would be the first thing I would try. Add a spoonful of apple cider vinegar to the, you can mix it in the keto-citra. It actually tastes pretty good, surprisingly. So I've tried it out. So it doesn't kill the flavor. So for some reason, it seems to work pretty well. So and that's pretty much the only tolerability issue we've come across, that some people, have GI problems. Maybe just to finish one thought, I didn't actually, I forgot to mention, as you mentioned, that gout sufferers might want to look into something like keto-citra. That's actually one of the things, as a company, Center for Nutrients, we're really, really interested in expanding and looking at the benefit of keto-citra in not only in polycystic kidney disease but other forms of chronic kidney disease. And maybe the top one that comes to mind is really gouty nephropathy, and in fact even hyperuricemia just by itself, I think, can be addressed quite well, as we already discussed. So definitely hyperuricemia, gout is absolutely on our radar. I would love to do a clinical trial with Rick Johnson, with Dr. Johnson, our mutual friend, and we've actually started to talk about this. So it'd be fantastic to, besides the dietary and lifestyle changes, to also have as a medical food, keto-citra kind of be part of the mixture there, which I think will actually be really beneficial. And I'm really glad that you seem to have some good results with trying it out for a couple of months. So that's really fantastic to hear, and hopefully you'll keep me up to date what happens, more long term as well.
Yes, fantastic. I really like it. Of course, what I have to say is anecdotal. I'm certainly not an experiment. But my regime is I'm pretty strict on my ketogenic diet, so I'm somewhere around 50 grams of total carbs every day. I measure biomarkers rigorously, so I finger stick for uric acid. Mm-hmm. At a minimum, fasting. And over the last 4 years, though, like I've tested foods, right? So I'll test before I eat, then after I eat, half hour, 1 hour, 2 hour, to track what happens with uric acid. This includes alcohol. So anyway, I'm just giving you that background. I push really hard on this stuff. Mm-hmm. And my regime right now is I take 100 mgs, I take 200 milligrams of allopurinol every single day, but I split it up. So I have 100 with my early meal in the day and 100 at my late meal. With the allopurinol, I have quercetin at both those meals, and I usually will do tart cherry in the middle of the day, right? And then I'm using keto-citra religiously every day now. And when I went on that, I was in the regime that I'm describing. Mm-hmm. And so I no one should take what I'm about to say literally, because it could mean absolutely nothing. But I seem to see another little increment of blood pressure lowering in the morning, mm-hmm. A little bit lower, and my urine pH is between 6 and 6.5, and it also seemed like my fasting uric acid came down a little bit more. My average is between 4 and 5 at this point. And I've listened extensively to Perlmutter and Johnson in this regard. And then after I've seen this most recent data with uric acid being deposited everywhere around the body, even in people that aren't ever going to have gout, that scared the bejeebies out of me, honestly. I'm like, yeah, I like keeping my uric acid between 4 and 5. I think that's a good idea, even though people, that's not medical advice. It's just what I do.
Mm-hmm. Excellent. Yeah. Wow. That's amazing to hear. And that's exactly what, I would expect. Wonderful. There's one more thing maybe to add, mentioning the ketogenic diet. So I think, so if you're fasting or you're going on a ketogenic diet, it usually causes a bit of acidification of the urine as well. And that may be actually the main reason, I think, why there can be sort of this fasting induced gout, right? So people can get a bump up in their uric acid levels if they're fasting.
Yes.
I don't think it's really clarified why that is necessarily. I would assume it has probably something to do with the urine pH going down, therefore uric acid levels in the blood go up because the kidneys can't get it out as well. I think it's actually really important when going on a ketogenic diet to be mindful of the urine pH, which always goes down, right? And using something like keto-citra to sort of like help, keeping it in a reasonable level. And that's actually why we're really combining this. We're recommending this plant-focused ketogenic diet in conjunction with keto-citra. And to just help, overcome this problem that somebody's uric acid might suddenly go up.
I think that's a really great statement that you just made. A really great idea. Yeah. I wish I'd known about this when I started 4 years ago, but we know now, and I hope that people that are listening to this will follow this up, because I think that your model with the plant-based diet is another plant-based keto is another option for them, because my model doesn't work for everybody. And, it's like you said at some point in our discussion, people are all different, and it's a matter of figuring out which way is going to work for them. And this is a viable option. And I like the idea of keto-citra at the beginning of the ketogenic diet for the very reason that you brought up. It's a really good suggestion.
Good. Super.
Is there anything you want to add before we close?
Just kudos to you, Pete. I think you're probably light years ahead of the maybe medical establishment with how to address hyperuricemia and gout. So I think you're doing fantastic work. I've been following your YouTube channel for a while now. I'm talking with Rick Johnson as well, and I think we're all are kind of on the same page with most of those things. And it will take a while for medical practice to change. But eventually it will happen. And I think, it's really important to get the word out there. And that's what you're doing. So thank you for that.